And welcome to a Unit 4 review. Wanted to just touch base. I know we talked about mood disorders in class, but it's always a lot of information. Thankfully, this is a short one. So we got our student learning outcomes. This is covering chapter 21 in your textbook. So again, we see this every lecture. Everything in psych is on a continuum. You're really, really happy, manic, or really, really, really sad, major depressive disorder. Emotional responses can be growth promoting and adaptive, or we get to ineffective behaviors. I'm going to go out drinking to cope. I'm going to go have unsafe sex with a bunch of strangers because that just makes me feel happy. Theories. All the theories are the same, right? For every different diagnosis, class of psych conditions that we talk about. Biological neurotransmitters, our brain, right? Serotonin is that main neurotransmitter when we talk about depression. Too little serotonin, and you have major depressive disorder. Too much serotonin, and you have mania. Hormones, postpartum depression, right? The change in those hormones. Depression can also be related to physical illness. A lot of times, chronic pain goes hand in hand. Our physical state can lead to a depressive state, or our mental state can affect us, differently. We're going to talk about this in a few weeks when we talk about somatic disorders, but you're really anxious and your stomach hurts. Psychoanalytical theory, right? That's Freud. Our mood disorders are our anger turned inwards. Behaviorists, it's a learned response. If we grew up and everyone in our family is just kind of always sad and mopey and depressed all the time, it's kind of just what we learn. Social theorists, that's how we interact socially. Holistically, it looks at spirituality, our mental state, our physical. Holistic is kind of where medicine is nowadays. We're going to look at every dimension of the patient. It's a little bit of that biological, it's a little bit of psychoanalytical, it's a little bit of social. Childhood. Situational depression is big in childhood, right? That's that Inside Out movie. Riley moves and she's really, really struggling. Something happens. There's an event, death, divorce, moving, right? They have a different way of thinking. And a lot of times they put all the blame and shame on themselves. If this is a kid who their parents, got divorced and they're like, because I did this, that's why my parents broke up. It's all my fault. There are huge amounts of incidence in depression in childhood, and it is increasing. The CDC actually just Monday released a new study that's 80 pages long that I'm trying to work my way through reading because I'm a nerd like that. And especially in teenage adolescent girls, right? It's just bad numbers, right? They're more suicidal than ever before. In adolescence, right, there's a lot of control issues. The teen wants to be in charge. They think they know everything. Hormones, right? That biological theory. Hormones are changing, and that contributes to the emotional ability. Self-esteem, social ideas, right? What happens to a teenager who doesn't fit in the box? Loneliness. What if they don't have friends, right? Your friends from childhood might be moving in one direction, they're moving in a different. Parent-teen communication is huge. Thrown in with family strength, right? I can't talk to my parents because they shut down. I can't talk to my parents about sex. Right? They also just think they know everything, and that causes fights with parents too because let's face it, we know teens don't know everything. In adulthood, we're expected to have emotional control, right? Your kid can have a temper tantrum in the grocery store, but adults can't. And if you do, you're called a Karen. We have a wider range of emotions, so as different things are happening, and there's a public stigma, right? No one talks about this stuff. Adults, y'all should be getting this in geriatrics, but depression is so common in older adults, and while it can be treated, many people don't talk about it, especially those older generations now. They were told just to keep it in. We have to ask adults, how are you doing? Are you having thoughts of hurting yourself? Is there anything you're struggling with? Right? Active listening. Be alert during your assessments. Sometimes they've been on medications for decades, and we need to assess, is that medication working? If they've been on an antidepressant for 20 years, do they still need to be on it? Or are they still depressed even though they're on it? And do we need to switch them to something new? Mood disorders fall into two spectrums. Depression, which is your sadness and disappointment, and your mania, which is that I'm going to be awake, I'm going to sleep for days, that pressured speech, right? That word vomiting, the flight of ideas. They're going to be more happy than you could even imagine, right? They're going to stay up for days. They're going to get in their car and do 180 miles an hour to go see their friend. And even though the friend's not there, like he's going to go in the house and you're just going to do whatever you're going to do. Depression, right? You might have a reduced need to sleep. They might just be too exhausted to even sleep. It's the cloudy mood. There's no bright light. There's no hope at the end of the tunnel, right? Someone's calling you to check in on you and you just can't. This is the person that wakes up and they got 2 spoons, right? And they need 7 spoons to take a shower and they can't take a shower. With depression especially, sorry, I'm getting distracted by this dog. With depression especially, we need to assess for suicide. Are you having any thoughts of wanting to hurt yourself? Are you having any thoughts of wanting to kill yourself? 3 types of depression. Mild depression is short-lived and triggered by a life event. You're really sad when your grandfather passes away, and it takes you a little bit of time to adjust. Moderate depression used to be known as dysthymia. This is that Eeyore, right? It's a moderate depression that lasts for 2 years. Chronically sad, self-critical. They see themselves as incapable or uninteresting, right? You're sitting there, head down, no one's gonna miss me anyway. Then you get to major depressive episodes. Major depressive is severe, lasting longer than 2 weeks. Paralysis, they might be easily agitated or irritable. And this is going to repeat, right? They might be able to slowly pull themselves out of it and then they go back into that depression. Not on the side is premenstrual dysphoric disorder, PMDD. That's found in females, and it's basically extreme PMS, right? Depressing and distressing emotions related to the menstrual cycle. A lot of times people just chalk it up to PMS, but it's more than that. And we actually can medicate kind of the week before the period starts to kind of help with those emotions. Okay, we watched this video, right? I'm not going to play it, but some of the common things we talk about in this video, or they talked about, anhedonia, that's a loss of pleasure. I used to be really happy playing the guitar, and now I just don't want to do it, right? You see a lot of guilt, sleep problems, fatigue. You don't have any energy to do anything. Difficulty thinking and concentrating. I couldn't make any decisions. Restless or agitated. You might feel like you're in slow motion. And then with the suicidal thoughts, we need to make sure we tell our patients to call for help. Remember, 988, that's the new suicide number, right? So just like 911, if anyone needs to reach a suicide self-help line, it is just 988. On the other end of depression is bipolar. So we have 2 types. Bipolar 1 is going back and forth from major depression to mania. So it alternates. Mania and bipolar 1 especially is what you think about when you think about bipolar. Higher highs and lower lows. It's more commonly diagnosed because it's easily distinguished. Delusions are more common, especially of grandeur. Hallucinations are not common but can be present. And because they're awake for days at a time, being awake and not sleeping can cause hallucinations. So sometimes that's where you see it. And it basically goes mania, depression. Because these psychiatric illnesses are chronic and lifelong, we're not going to give a med and fix the bipolar. We're just going to give meds to stabilize that mood, right? And we're usually going to give lithium. Bipolar 2 is less frequently diagnosed because it goes from periods of depression with hypomania. The mood swings are less dramatic. This is your super fun friend Amber, who we all think is just wild, and she's going to be like, let's drive to Oklahoma and go to the casino. And you hop in the car Friday night, next thing you know, you're like on a random road trip. And then they have 1 or 2 weeks of just kind of severe lethargy. They're just withdrawn, they're melancholy, and then they're right back out, going bars, having fun, gambling. Because behaviors aren't as unsafe, safety isn't as big of a concern as safety is with bipolar 1. So bipolar 1 is your typical bipolar that everyone thinks about. Bipolar 2 is your super fun friend who goes between being super outgoing, let's go, 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 and kind of just down in the dumps for a few days, right? We watched this video, right? She had the clothes, she had that pressured speech, she kept getting up in the boundaries, right? We need to make sure we're setting limits. Call the doctor, be like, are you really taking your meds? Because if you're acting like this, I bet you aren't. This was the video where we talked about hypomania, right? She was very fidgety. She was aloof. She laughed in weird places and kept changing the subject. She slept, but it was for maybe like 2.5 hours. So she's not really manic. She's just kind of off. Cyclothymic disorder, right? Cyclothymic, cycle. So that's going through the different stages of bipolar repeatedly. And it's a little bit faster. So hypomania, depression, hypomania, depression, hypomania, depression. Well, someone might be depressed in bipolar 2 for 2 weeks. In cyclothymia, they're down in the dumps for a few days, and then they're manic for a few days, and then they're down in the dumps for a few days. They switch back and forth between them a lot faster. Seasonal affective disorder that's winter depression, right? It occurs in the months where we don't see the sun, and in part because there's less exposure to the sun. It's also kind of hard because of the holidays, right? If you don't have a family or don't have a good family, it could also be hard for you. Treatment is going to be light exposure, right? We're going to sit them in front of a special light that mimics the sun, and that can help lessen the sadness and the social withdrawal. We need to look and worry about blurred vision and jitterness, just like if someone's going to go in a tanning booth, right? A lot of the same things. You can also see this in people who work night shift, especially in a hospital. You're inside, you never see the sun, you're working all night, you're sleeping all day. Disorders. Baby blues and postpartum depression. Baby blues is kind of what we consider normal, right? A little bit weepy, crying, kind of just not feeling like yourself, a little bit more irritable. Right after baby, you're awake all the time. It just takes time for those hormones to rebalance. And a lot of it's just because of lack of sleep. Postpartum depression takes it a step forward, right? The hormones are more so over itself, but now you're throwing in a lot of the major depression, right? The lack of energy is to the extreme. The weepiness is to the extreme. Excessive worry. Like you're terrified of everything that has to do with the baby. How am I supposed to be a good mother? My kid's going to die. This is going to happen. I can't do it. When am I supposed to feed him? Feel guilt, right? You feel alone and irritable. Postpartum depression, I want to say the statistic, and actually I was reading it today, is like 10 to 20% of births. The mother will experience some form of postpartum depression. This gets screened for at the 6-week follow-up for baby. So pediatricians will even screen for this since it deals with the birth of a child. Not on here is postpartum psychosis, and it's a result of the postpartum depression not being treated, and it just goes and goes and goes until all of a sudden the mother is having hallucinations that's telling her that she needs to kill her kid. Your kid is the demon. You need to go stick them on the train tracks. You need to drown them. It's common. The one everyone kind of knows about is Andrea Yates, where she killed all of her kids. There is just Lindsay Clancy, who just killed her 3 kids and then jumped out of a window. She had postpartum depression, which with each pregnancy getting worse and worse and worse. And then she wound up with postpartum psychosis. This is in 0.08 to like 2 out of every 1,000 pregnancies. So it is super rare. Substance-induced mood disorder, it's due to the fact that you're on a chemical. I've been drinking alcohol and now I'm extra emotional. It can be any substance. You can see mood disorders and psychosis disorders, with steroids. Someone gets on prednisone. If you weren't using the substance, you wouldn't have the mood. So we take away the substance and you're all better. Therapeutic interventions, treatment and therapy, right? Acute treatments the first few weeks. They're going to be inpatient for maybe 5 to 7 days, right? If they're inpatient at all. We're going to continue watching them for 4 to 9 months. And then after that, it's indefinite. This is a lifetime treatment. It's a long-term chronic illness. We're going to treat with psychotherapy, right? Every one of these conditions that we're going to talk about needs therapy. Pharmacological, right? What meds are we going to use? Probably SSRIs. They're going to be our first line just because they go so well with so few antidepressants. ECT, electroconvulsive therapy. This is old school, right? Electric shock therapy. We're going to shock them. It causes a seizure and it resets the neurologic system. Very formal now in a facility with lots of sedatives. We see a lot of confusion and short-term memory loss often, but that ECT is a last resort. We have given you all of these meds. You've been doing therapy and absolutely nothing is working. So we try ECT. Transcranial magnetic stimulation, that's that bottom one. I don't know why they call it direct current stimulation on this slide. But TMS uses a magnet. So it's a newer version of ECT, and they kind of trigger a magnet point at your head. It works really well, less of the side effects of ECT. It's done on an outpatient basis. The problem is you have to go every day for like a month, for like an hour or two to get this done. So most people can't do it. Antidepressants, lots of antidepressants. Ooh, we have that separate video that I made where we talked about it. It's hard because most people, especially in America, we want a quick fix, right? But it's going to take 2 to 4, sometimes 6 to 8 weeks, depending on the type of antidepressant to fix it. Tricyclics, they're the ones that kill you. If you overdose on it, if you take too many, you're going to die. Non-tricyclics, we don't really talk about. I wouldn't worry about them. MAOIs, right? That's the diet, the tyramine. You eat your charcuterie board, well, on an MAOI, you have a hypertensive crisis. SSRIs have less side effects, right? They work by increasing serotonin in the neuraptic clefts, and it's generally our first line just because there's so few side effects and they're so safe. Atypical antipsychotics, your Wellbutrin and your Remeron. We honestly see Remeron more for sleep. With antidepressants, because it takes so long to work, we need to assess for suicide. Because when someone is truly majorly depressed, they don't have enough energy to kill themselves. We give them an SSRI, the serotonin starts increasing, and all of a sudden they have a burst of energy. And that burst of energy causes them to then kill themselves. So we have to assess frequently for suicide in the beginning period. Many people who are depressed are at high risk for medication compliance because it takes so long for everything to work and they just don't want to deal with it. And 2, even SSRIs, they still have side effects, right? There's still a lot of side effects that we need to watch out for, and that's why they stop. Serotonin syndrome, that's in your other PowerPoint. You take too much SSRIs or add an SSRI and an SNRI together, and we slowly start to increase your serotonin until it gets to dangerous levels. High risk causes seizure, coma, death. So we need to watch out and educate our patients on the symptoms of that, but also only take one medication at a time unless your doctor is aware of it. Lithium is huge. Lithium is our baseline medication, what we're going to use for bipolar. Tables 21.4 and 21.5 in your book are good tables to look at, right? So lithium's a salt, so we're worried about sodium. So we have to monitor water intake. If the patient is drinking a ton of water, we need to assess them. Therapeutic range is 0.6 to 1.2. Galen standard kind of looks at 1.5 because that's where we start to see toxic levels. We're going to talk about the signs and symptoms on the next slide. It's the usual drug of choice, but patients like being manic, so they stop taking it. I have more energy. I can get more done. We do regular lab draws. If the patient slabs comes back as a 0, we're going to call the patient. We're going to assess to see, are you actually taking your medication? Because your lithium should never be 0 if you're taking lithium. We need to be aware, especially with the salt, anything that can cause dehydration. So if your patient just took up a hobby and now they're playing like basketball outside in the summer in Texas and they're sweating, and they're getting dehydrated, we're going to be concerned because dehydration increases the lithium level, which puts you at a higher risk for lithium toxicity, as does a stomach bug. You have someone who's stable on their lithium and their kid comes home from school and brings, the GI, whatever that's going around the school, and now everyone's puking, and has diarrhea. It could raise that dehydration, their lithium level. What happens when we raise the lithium level? We wind up with lithium toxicity. So mild is kind of that 1.2 to 1.5, right? A little bit of twitches, apathy, sluggishness, you can't concentrate, nothing crazy. But moderate's at 1.5 to 2.5, and that's what we need to look out for. Because if we start to see these symptoms, we want to catch it in that moderate range before it gets to the severe, right? Ataxia, tinnitus, ringing in the ears, blurred vision, nausea, vomiting, diarrhea, slurring of the speech, right? You had sluggishness with mild, but now it's increasing sluggishness. It's getting worse. You had muscle twitches with mild, but now you're getting tremors. Severe, right? Lots and lots and lots of twitchiness. Nystagmus, that's the eyes, right? Muscle tremors are everywhere. One muscle group might be twitching. Hyperactive tendon reflexes, for whatever reason, if you see a patient with hyperactive tendon reflexes, at least in my psych nurse brain, lithium toxicity or serotonin syndrome. Urine outputs decreasing, right? Lithium's a salt. We're retaining water. Hallucinations, grand mal seizure, coma, and death. We have to be familiar with lithium toxicity because it's just so dangerous in these patients. What are we going to do, right? As nurses, assess for level of depression. And honestly, we assess it by saying on a scale of 0 to 10, what level is your depression? Right? Mania will be like, hey, we were running on them every 15 minutes. They were awake for 2 days. We're going to choose our nursing diagnosis and our interventions based on the client's most distressing problem, right? We're going to start at the bottom of Maslow's hierarchy, and we're probably not going to get above the first or second level. We're going to set limits, right? Especially with manic patients, same as with their personality disorders. They're going to try to get up in your boundaries, and we have to set it, right? Manic patients, if we're doing a care plan and they're not eating, right? They might not be sitting down. So we're going to want to make sure we offer them small, frequent foods, have lots of cups of water. Here's a protein shake, right? And by protein shake, I mean Ensure. Here's a Gatorade. Holistic interventions, physical, emotional, social, intellectual, and spiritual, tie everything together. Some people do well, going to see the religious counselor, for intervention. Some people do best in group therapy. It's going to depend on everyone. That, in a nutshell, was Unit 4, Mood Disorders. If y'all have questions before this next test, let me know. If you're even watching this before then. If not, I will see you on Monday for your exam. Have a good night, y'all.